Live. Good evening and welcome. I'm Nora Kane. I'm the director of the Stanford Health Library, and it's my pleasure tonight to welcome Dr. Morton of Stanford's Bariatric Medicine Department and General Surgery here at Stanford for a talk on updates on treatment for overweight and obesity. And it's a particular pleasure because Dr. Morton has been a wonderful participant in our community lecture series over the years and has followed us from location to location, and he's here tonight in our Hoover Pavilion for the first time. And so just so by way of introduction, I'd like to let you know a little bit about him. As I said earlier to him, I could go on and on reading from his CV because he is so accomplished. Dr. John Morton is the Chief of Bariatric and Minimally Invasive Surgery here at Stanford University School of Medicine. He also heads the Bariatric and Minimally Invasive Surgery Fellowship and is the co-director of the Stanford Digestive Health Center. He received his undergraduate master's in public health and medical doctor degrees from Tulane University and a master's in health administration from the University of Washington. He was the first surgical resident to receive a Robert Wood Johnson Clinical Scholar Fellowship in the program's history at the University of Washington, and he also completed an advanced laparoscopic fellowship at the University of North Carolina in Chapel Hill. He is somebody who really is an achiever, as you can tell. He has published over 100 peer-reviewed articles and 15 book chapters with over 200 national and international presentations. His research has focused on quality improvement and bariatric surgery. And so it's my pleasure to introduce tonight Dr. John Morton. Thank you very much, Dr. Morton.
Thank you. Thank you, Nora, and I want to thank the Stanford Health Library for the opportunity to present this topic to you all. Really appreciate the audience coming out tonight. I know it's a school night, but we'll make sure that we get some information across to everybody. I'm going to talk about something that really affects many of us in the United States. It's at least a third of us have some issues that we have to deal with when it comes to our weight. And I'll tell you, things are very different now. We have a lot of options available to folks that weren't available even a year or 2 years ago. And that's the thing I want to really get across most of all, is that there is opportunity and there is hope for doing something when it comes to your weight. I'll first tell you a little bit about our group. And you can see there, it's not just myself, but we're composed of many different parts of medicine. And we've been recognized as a center of excellence by all these different health insurers from all over the country. And part of it is because we're dedicated, we focus our resources. We also are able to provide, I think, very good outcomes. And ultimately, we've got good dedication to our patients. And ultimately, that's what it's all about. And as you'll hear a little bit about this in just a moment, this is really my life's work. This is really what I'm truly interested about treating a disease. And as you can see here, our clinic is composed of more than surgeons. We have internists that work with us. We also have people that are involved in other areas, our psychologists, our nutritionists, even plastic surgeons. We're a big believer in patient education, and we have our support group leader there, and you see her listed. She is also a patient who formerly had bariatric surgery, and she's a nurse. So she can really tell you a lot about what's involved. The big thing I'll talk to everybody about tonight is what's going on when it comes to weight in this country. Unfortunately, we haven't seen the obesity crisis slow down. If anything, I'm concerned about the future for one reason, that last bullet point that you see up there, and that is that obese kids grow up to be obese adults. And right now we're seeing that particular group increase over and over again. What's the biggest risk factor for obese children? Obese parents. And as I'll tell you at the end of this talk, it's important that whatever lessons people learn around their diet, their exercise, their sleep, their stress management, that you pass that on to other people. And that includes your friends and your family. So what causes obesity? If you take a look here, it's a very long laundry list. And you can see there it's everything from genetics to how we live. Now, our gene pool did not change in the last 20 years. What has changed is how we live, how we work, how we play. We certainly don't have as much time as we used to anymore to prepare our meals. We don't have as much time to exercise as we did before. We're sleeping less. All of those things are leading to us gaining weight. And I really think that's the biggest thing. The other thing that we do know is back in the old days, maintaining your weight was really critical because we weren't sure where our next meal was coming from. So that's why our bodies are so incredibly efficient at retaining each and every calorie. Nowadays, where we have food available everywhere, it's not so important that we maintain those calories all the way to the end. In fact, you know, you can step into just about anywhere now and there's food available. The other day I was looking at buying some furniture. They had candy out. Not sure what a furniture store needs to have candy out for, but it just shows that we have food everywhere we go. And as you can see here, what's really changed is what we're eating. Less fruits and vegetables, more fast food and things like that. And I really want to emphasize the sleep part. Our sleep doctors right here at Stanford have been looking for a long time for a blood test that can tell us if someone is sleep deprived. And they finally found it. It's something called ghrelin. And as I'll show you, that's a hunger hormone. So the next day when you're tired, you're going to look for energy in a lot of different ways. And you're going to look for energy through food. You know, I remember being on call as a surgery resident, being tired, you know, the next morning. For some reason, I always wanted pancakes the next morning. And it's part of the reason, as I said before, is that your body knows it's stressed out and it's trying to get calories. I'll talk to you a little bit about what's the best way to define obesity. And you can see up there a former governor, Mr. Universe 1975. And really what we're measuring here is height and weight. And that combination gives us something called body mass index. Now here's our governor a little more recently. And you can see there, it's true of even Mr. Universe. Even Mr. Universe can gain weight. And so that can happen to everybody. This guy is obviously in incredibly good shape. One thing that's really changed for us in this field of treating people who carry extra weight is recognition. That this is something more than a willpower issue, it's something more than a psychological issue. This is truly a disease. American Medical Association, our leading medical society in the United States, over 500,000 physicians compose it, declared it a disease back in 2013. And if it's a disease like any other, it's got stages. And what do we want? We want to be able to treat that disease at early stage. We don't want to wait too long before treating it. Because as you can see there, once you get to stage 4, which is a BMI over 50, that's a serious consequence that can really shorten your life. The other thing that we do know is that when you carry extra weight, you're going to carry extra medical problems. We're right here at the Hoover Pavilion that composes a lot of different specialties, and it doesn't matter what field of medicine you're in, you're going to deal with obesity. Whether you're an orthopedic surgeon who has to replace a joint because that joint has been worn down through the extra weight, whether or not you're an endocrinologist who treats diabetes, and we know that obesity and diabetes run together, even if you're a gynecologist treating infertility, you're going to deal with weight, because when you carry extra weight, decreases your ability to become pregnant. Even areas we don't traditionally associate with obesity, like cancer, is well associated with obesity. Doesn't matter what kind of cancer, as you can see behind me, your risk of dying from that cancer goes up when you are carrying extra weight. And again, it has a lot of different reasons that come up, but it shows the effect that obesity can have on all body parts, all diseases. I'll mention one other disease, and that's the disease of medical complications, if you will. You know that there are certain interventions we have in medicine that can lead to potentially complications. A big risk factor for complications after treatment is carrying extra weight. And here's just one example of it, and it's within orthopedic surgery. Hip and knees are replaced about 1 million times a year in the United States. And one of the biggest risk factors for infections after these operations is carrying extra weight. The other thing is that joint that's meant to last for 30 years, if you carry extra weight, it's only going to last 10. And it may not function as well. So this is another, if you will, complication of carrying extra weight. Now, what can we do about it? At what point should we intervene? I already told you about BMI in different stages. As you can see here, and I'll use this little arrow to show you, when you really start to worry is when you get to that BMI of 30. That's really when you start to see the mortality rates go up. So it's pretty early. Back in a few years ago, people were advocating that we have more than 4 vital signs. And I think the 5th vital sign should be BMI. It should be something that we're looking at each and every time you have contact with a medical professional. And to that end, if you have a BMI over 30, it's time to start talking to your physician about what's available. And as I'll show you, lots of options available. The other thing I want to show you is that this is a relatively new phenomenon. This is not something that's occurred over time, over like 50, 60 years. It's really been the last 20 years or so that this has happened. And this is a survey called the Behavioral Risk Factor Survey, and it's from the Centers for Disease Control. This survey is the same each and every year. The other thing that's interesting about this survey, it's a phone survey. So I don't know about you all, but if someone calls me up and asks me my height and my weight, I'm going to gain a couple of inches. I'm going to lose a few pounds. So this is likely an underestimate. But if you look here back when we had President Clinton, you can see that there were very few states that were greater than 15% obesity in those states. But let's look what happened over time really quickly here. Now this is the same survey. You see the colors are changing already in such a short amount of time. And finally we get to where we have that new color, and that is the state of Mississippi. And you can see that in that state, at this point, greater than 25% of that state's inhabitants are obese. I'm originally from Alabama, and our motto was thank God for Mississippi, because otherwise we'd be last in everything good and first in everything bad. I didn't have much time to crow, though, because Alabama joined it the next year, along with West Virginia, and so on. Same survey, all through the phone. We have one blue state left, that's Colorado, the healthiest state in the country. Will it hold out? We'll see. Nope, it didn't. So you can see now this is an incredible change that's occurred in a short period of time. In fact, if you showed this to an epidemiologist and you look at diseases, they would say this looks like an infectious disease because it's spread so quickly. In fact, if we took everybody who qualified for weight loss surgery in this country and put them into one state, we'd have a whole new state of obesity. And you can see there that's 18 million people who qualify for weight loss surgery in this country. So that just goes to show you people are not alone. There's a lot of folks out there that need help. And it's not just a U.S. problem, it's a worldwide problem. And you can see that listed here. In fact, countries we don't traditionally associate with weight, like say China, is dealing with it now. In a country of 1 billion people, 10% of that country is diabetic. And the main reason is because their weight is going up. Interesting thing is if you're of Asian descent, your ability to get diabetes occurs at a much lower BMI. And what's happening here is that China's not immune to Pizza Hut and KFC and all those different food outlets across the country that are now overseas. And that's one thing they have to deal with. I think I've already painted a picture here that shows that this affects a lot of different diseases and it has impact. In fact, this one author wrote this article not too long ago, maybe about 5 or 6 years ago, and said if we keep going in the same direction, we may actually see life expectancy go down for the first time in a long time. I think we're raised in the U.S. to believe in the American dream, which is that the next generation is going to be better than the last. That's what we've always hoped for in medicine. But if you look here, this has changed, and it's changed this year. This was a prediction that people made about life expectancy might go down in the next few years to come. It actually did go down last year. And one of the reasons that it's attributed towards is us carrying extra weight. The other point I want to make is that when we carry extra weight, you can't talk about anything in healthcare without talking about costs nowadays. And if you look here, as your weight goes up, the money we spend on your healthcare goes up as well. In fact, if you look here, we spend about $300 billion on obesity-related medical costs. And it might be an underestimate because don't forget diabetes, heart disease, joint disease, all of it is very closely related to obesity. Now, people ask, do the insurance companies cover weight loss surgery, bariatric surgery? They certainly do, and they don't always do it out of the kindness of their hearts. They do it because it actually works, and they get return on investment, as you can see from the study, in as little as a couple of years. The other thing I want to point out is how much money we spend in other areas of healthcare. This shows how much money we spend on Obamacare. It's been in the news a little bit lately. And they spend roughly about $200 billion to institute that. Remember how much we spent on obesity? We'd have more than enough money to pay for Obamacare and other coverage if we kept obesity rates at lower levels. This is a study that we just finished completing where we followed our patients who had weight loss surgery versus those who didn't. And just to show you here, the green are the ones who had surgery. And you can see that their cost went down. And you can see the people that didn't have the surgery, their costs continue to go up. Maybe the way to address healthcare costs in this country is to help us address carrying extra weight. And I think that's something that we've got to look at. The other thing I want to point out, there's a healthcare cost associated with it. There's a medical cost, with all the diseases, but there's also a social cost. I've operated on about 3,000 patients and treated more for weight loss through our medical weight loss program. And I can tell you, nobody wants to carry extra weight, not a single person. And you can see from these two pictures here, this represents Mike and Molly, as well as the show Roseanne from a few years ago. And if you ever watch these shows, almost all the jokes are around people's weight. And it seems like it's still okay to make fun of people who carry extra weight. Can't make fun of other people, but it still seems to be okay. And it unfortunately has consequence. Has consequence about getting that job promotion, has consequence about getting into colleges, a lot of cost that's associated with it. Isn't it interesting to see what happened to Roseanne? She had gastric bypass surgery. John Goodman had something done. He won't admit it, but he had something done. And you can see that he benefited from weight loss. The other thing I want to point out is that this stigma extends in a lot of different directions. We just went through a presidential cycle, I think you guys know, and this one columnist said there was one candidate who shouldn't run for president because he's frankly just too, I don't like this word, too fat. It's the new F word, one we shouldn't use. And you can see here that he said, this guy shouldn't run for office. He was talking about Chris Christie. Yeah. And so one thing that another columnist said, that's not right. Just because a guy has, a health issue doesn't prevent him from seeking higher office. Our own former president, Obama, used to smoke. He's quit now. That didn't keep him from moving up. FDR, one of our greatest presidents, that was a big-time chain smoker, didn't keep him from seeking higher office. Shouldn't keep, regardless of your politics, I think the one thing we all agree on, everybody ought to have an opportunity in the United States. And you can see here that the governor's made a lot of progress over time. And we definitely try to teach this in a lot of different ways to our medical community. Because the one thing I do know is that people who carry extra weight don't often get the care they need and deserve. And you can see from the study we did a few years ago, if you carry extra weight, you don't get the same level of preventative care. You don't get colonoscopies at the same rate, or mammograms, or pap smears. And that's something that we want to change. We try to change it here at Stanford by teaching our medical students about carrying extra weight. So hopefully, I've painted a picture here that shows that we've got to do something about this. If you look at all the different issues that occur with it, and I'll outline some of the things that we can do to help. And as I mentioned to you before, I couldn't have given this talk a couple of years ago because so many of these things are brand new that we can offer. And I'll show you here a couple of things. This is just an experience that we've had at the Stanford BMI clinic, and we do everything from medical weight loss to endoscopic weight loss to surgical weight loss. And you can see all the success we've had through our patients over the years. A couple of things to kind of keep in mind. A lot of the old medications that you saw associated with weight were not always associated with good outcome. And these are old medications. In fact, if you look at some of the outcomes, people didn't lose a lot of weight with those old medications. On average, maybe 4-6 pounds at the end of the year. Now we're seeing some different things that are occurring. And the one thing that we're seeing is that we have brand new drugs that actually work. And we can use them in concert with our other procedures, whether they be surgery or endoscopy or standalone with medication. And as I'll show you on this next slide, you can see all these medications were approved pretty much in the last 2 to 4 years. You've got all the ones listed there, and they do work and they do help. In fact, I'll show you our own experience at Stanford. You can see this is our medical weight loss program. It's not going to be surgery, but at the right stage of disease, it can make a big difference. You can see there that there are some patients that lost at least 10% of their total body weight. So it can make a big difference for them. Now what we do is we're very careful about figuring out which medication is right for you. We also try to prepare our patients for surgery and helping them lose weight ahead of time. And that concept is important. People who watch the Olympics, one of my favorite events is the relay race. And if you ever watch the relay races, they never hand off the baton standing still. They're always running, right? And this is important. So we want to accelerate that weight loss, whether you're having it through surgery or endoscopy, and we can use medications in that way. I like to consider it kind of like, what we do in cancer. You've heard the term adjuvant chemotherapy. Sometimes they give chemotherapy before you operate, and it actually shrinks the tumor, makes it easier to do surgery. This is the same concept in using the medications before we do weight loss surgery and helping people lose weight. The other thing I wanted to point out to you is there's something in between medications and surgery, and that's something called the intragastric balloon. And this is, again, brand new in the past year. This is really meant for low BMI patients, BMIs 30 to 40. It's not meant to replace surgery or compete with it. It's temporary, so it's only in there for 6 months. We're able to do this all through the mouth, no incisions. It's a fairly quick and straightforward procedure. And as I'll show you here in the next slide, you can see what it looks like. This is one of the balloons. There's many of them, but this is the one that I employ. And it's got 2 large balloons that are about 900 cc's. And they stand for 6 months. And as I'll share with you, we've had good results with it. Now, what happens when you take out the balloon at the end of 6 months? You can see here from this study that was done overseas that 80% of those patients are able to keep their weight off at the end of beyond 1 year. We just finished doing a study where we looked at comparing the FDA trial, the one that got the approval for the balloon, to what our actual experience was. And you can see that we actually did better than the FDA trial. People lost a considerable amount of weight, and you can see there that the people lost about a third of their excess weight. So again, not like surgery, but something in between. Think of it like cardiology. You know, in cardiology, you got the anti-cholesterol medications, you got open heart surgery, and in between are the stents, those little things that open up the clogged arteries. Endoscopy for us is kind of like that stent. And I wouldn't be a weight loss specialist if I didn't have show and tell pictures. And you can see here, this is one of our balloon patients. On average, our patients have lost roughly about 40 pounds. And also want to demonstrate what we know about diet and exercise. Whatever happened to that? Why can't we lose weight on our own when our BMI is over 30? And as I'll share with you, it's pretty hard to do. Only about 5% of patients are able to do it, 1 out of 20. And one of the reasons, as I'll point out, is that your body's not working for you, it's working against you. Now this shows diet and exercise alone and how much weight people lose. At the end of 1 year, you can see there it's about 6 pounds, not a lot. And why is that? Why is it so hard to lose weight on your own? Well, this is taken from Weight Watchers, and this shows how many people are able to stick to the diet. The reason diets work is your ability to stick to them. This is the adherence rate. And you can see there at the left hand, you can see there that's probably January. Everybody starts out with New Year's resolutions. 100% are on the diet. But at the end of 1 year, you can see that very few people are still on their diet. And one of the reasons is it's hard to stick to that diet, as I'll show you. In fact, what we're noticing is that around the country, less and less people are sticking to their diet. And that's something that's occurred over time. And you may ask yourself, wow, our obesity rates are going up and less people are dieting. What's going on with that? Well, one of the reasons for that is a rational response to when diets don't work. And if they don't work, then why would you consider doing it? What's the definition of insanity? Doing the same thing over and over again, expecting a different result. And so what we have to do is understand what's going on and see if we can improve it. This is a terrific article that showed that it's hard to lose weight on your own. And it showed that your body's having to overcome a lot of different things to allow you to lose weight. And one of the studies that really demonstrated this super well was the Biggest Loser study. I don't know if you guys saw this, but this was fascinating. I'm not a big fan of that show. I know that the purpose is to help people to lose weight. I'm not a big fan of how they do it. A lot of it is humiliating, and a lot of it is not sustainable. People cannot do that forever. And this is what happened to the Biggest Losers afterwards. Do you see what happened? Every single one of them regained their weight, except for one. One right there did lose weight. That particular patient actually ended up having bariatric surgery. And so this shows when you're dieting how hard it is to lose weight on your own. And these were motivated people. Don't tell me they're not motivated if they don't come on a national TV show. Those people are motivated. So it's not motivation. It's not psychology, it's physiology. Here's another study that shows what happens when you're carrying extra weight and you're trying to lose weight. The peaks correspond to breakfast, lunch, and dinner. The black dots are after you dieted, and the white dots are before you diet. Your body's not stupid. It's going to do everything in its power to regain that weight. And you can see that. It actually bumps up the hunger hormone. So it is not a myth, you know, that people have trouble losing weight. In fact, I'm sure everybody in this room at some point or another, including myself, have dieted. And if you've ever dieted, sometimes you've regained that weight and then some. Now, what happens to this ghrelin level? You know, if, say, with surgery, you can see here that that ghrelin level is about close to 0. Now, that's not forever, but it lasts for about 6 months. And you can see that that really helps to introduce new habits. That way people can have lower volume for their diet. They can eat more protein, less carbs, and this way they don't have their body working against them, they have their body working for them. One point I like to make about surgery and the role it plays in dealing with obesity is it's not very different from what we see in other fields of medicine. When we're first starting out to deal with a disease, surgery is often there first. as a first responder. Before we had all the chemotherapy and the different therapeutics for cancer, surgeons were there first. TB used to be a surgical disease that was treated actually through chest operations. Now we treat it all with antibiotics. Same deal with heart disease. So I'm not surprised that surgery is here first. Not to say that we're going to treat everybody surgically, but at least we shine a light on the problem and we can help one patient at a time. Now, who qualifies for weight loss surgery? As you can see behind me, it's someone who's got a BMI over 40 or a BMI over 35 with a medical problem. We want to make sure that patients are well prepared for surgery because think about it. What else do you do 3 to 4 times a day, every day? That is a difficult habit to unwind, and so that's why we have psychological support if needed. Now, these are the different procedures we offer at Stanford: the band, the sleeve, and the bypass. The band is not a procedure we do very much anymore. This procedure in the beginning was met with a lot of enthusiasm, but roughly about only half of patients are able to keep weight off with the band. The way it works is pretty simple. It's like putting a belt across the stomach, and you can tighten it up or loosen it as needed. It is a pretty safe procedure, but it is a device, and it can slip, slide, and erode. Because of that, that's led to this operation called the sleeve gastrectomy, which is now the most popular operation in the United States. And what we do with this operation is we take the stomach, that's roughly about the size of a football, and make it into a long skinny tube, roughly about the size of a banana. And you can see there that there's very little chance for having issues with vitamin deficiencies. And as you can see from the next slide, people lose roughly about 60% of their extra weight. Very low complication rate, as I'll show you in just a little bit. Now, the gastric bypass is an extremely interesting operation. This operation is truly a metabolic operation. By that I mean that it is able to not only let people lose weight, but also have them get rid of their diabetes, high blood pressure, even increase people's testosterone. In fact, after this operation, in as little as a week, people who were on insulin before are no longer on insulin afterwards. So it's a pretty remarkable operation. We're trying to figure out exactly how it works, but it is a very unique operation. The one thing I'll tell you is that, at Stanford, we do all these procedures laparoscopically with little incisions. People are in the hospital for 1 day, maybe 2 days. Now, the other thing that we can also tell you is that the gastric bypass, as I showed you there, is an excellent operation. There is chances that you could be low on vitamins. What do we do to prevent that? You take your vitamins every day, and we do check your vitamin levels when you come back to see us. People often ask what happens to that old stomach. It just stays in there. It doesn't cause any harm, just kind of hibernates. Now, even though we do this through little incisions, it's still a big operation. And you can see there's always potential for complications. But I'll share with you, we've taken this lesson to heart, is that first, we do no harm. We want to make sure your safety comes first when it comes to any sort of procedure. In deciding which procedure, you can see there the ones that we offer: band, sleeve, and bypass. Like I said, people are in the hospital for a day or two. If your BMI is over 50, if you have bad acid reflux, or if you have bad diabetes, in general, the bypass is going to be better for you. I'm a big believer in preventing complications. Old Ben Franklin quote, "A stitch in time saves 9." I was a Boy Scout. Other big motto I like is be prepared. And so these are some things that we try to do to prepare patients before they have surgery to prevent problems. So to prevent ulcers, you can see that we have medications to prevent gallstones, different medications to prevent those vitamin deficiencies. We give you your vitamins. Now, people often ask, it sounds great, terrific to lose weight. Is it possible to regain weight? And the answer is yes. And it's just like anything else in life. If you tend to follow the rules, things tend to work out for you. So a couple of things to kind of keep in mind to avoid afterwards. These are some of the things that are actually important for any of us, whether or not you've had bariatric surgery or not. Grazing, that's kind of how it sounds. If you nibble a little bit all day long, that will catch up to you. And so what you want to do is stick to your set meal times. And it's as simple as 4 by 4, 4 small meals, 4 hours apart. The other thing I want to caution everybody about are liquids. I have water here. As far as I know, it's 0 calories. And the one thing you do want to be careful of with these liquids are that some of them can have quite a few calories. One to kind of think about are the different coffee drinks. I'm not going to mention anybody in particular, but if you look at some of these venti mochaccino lattes with the whipped cream and the caramel and everything else in there, it can be almost 700 calories in a cup. It's like a Big Mac in a cup, and we don't think of it that way. Simple thing to do, instead of having the latte that's 200 calories, have a black cup of coffee with a little bit of milk. That's maybe 5-10 calories. Right there, you've exchanged a big chunk of your calories. Your body's so finely tuned. If you have one lifesaver a day, that's roughly about 5 or 10 calories, it's going to result in 5 to 10 pounds at the end of a year. So it makes a difference. And as I mentioned to you before, liquids are important. The other liquid that you got to be careful with is alcohol, because alcohol carries calories. Alcohol, a single glass of red wine, it's about 120 calories. You do that every day, keep everything else equal, that's 12 pounds at the end of the year. So you got to be careful with that. Last point I'll make is about nighttime eating. And you really want to be careful about eating too much right before you go to bed. Your metabolism slows down, and if it slows down, you're going to be able to keep those calories better, which is not what you want. This is an old sumo wrestler trick. The sumo wrestlers, in order to gain weight, would have a big meal, a few beers, and go right to bed. Terrific way of gaining weight. A lot of my patients are women, and I always tell them you should eat like a queen for breakfast, a princess for lunch, and a pauper for dinner. That's one way to remember it. And there's great studies that show you cannot skip on breakfast. What your mom told you is true. Don't skip breakfast. And I know you may not feel hungry. You don't have to have a lot, but it's good to have some protein to start out. Because if you have those big calories at the end of the day, they're going to stick right here on your tummy. So something to kind of keep in mind. For us, at Stanford, we're always looking for ways that we can improve. One thing that we want to avoid is making sure that no one gains weight right before surgery. And as you can see there, it does increase your risk of complications. Many years ago, we did several studies to indicate that if patients lose weight before surgery, they're able to have a better outcome. And as I showed you before, with our new medications that we have available, it's totally possible for that to happen. The other thing I want to point out is the role that exercise can play. And just by giving our patients a simple pedometer and measuring how many steps they were taking, they increase the amount of weight that they lost versus those who didn't have the pedometer. What's the simple goal when it comes to exercise? Is 10,000 steps a day. That's what the Surgeon General recommends, and that's something that's pretty easy to do. Now, I want to make one big point here. Diet comes first. 80% of weight loss is going to come through diet. You have to burn 3,500 calories to lose 1 pound. I don't know about you guys, but when I'm on the elliptical and if I do 300 calories, I'm thrilled, but you got to do that and more each day for the entire week to lose 1 pound. You know the saying, a moment on the lips, forever on the hips. It's true. Diet is where it starts. We always encourage our patients to try to get into exercise. This one patient interested, I don't know why, in roller derby. That's how she lost her weight, and she was able to keep it down through exercising. Anytime we're talking about surgery, we have to talk about two things, safety and effectiveness. And as I'll show you here, we've made a lot of gains when it comes to patient safety in bariatric surgery. A friend of mine and I wrote this article a few years ago where we call for the establishment of specialized centers that devote themselves to the care of the patient carrying extra weight. And since then, we've made a lot of progress. As I'll show you here, we now have this accreditation model where we have about 800 hospitals in the United States now that are accredited for bariatric surgery. And what have the results been? You can see here that the mortality rates declined almost 100-fold in a very short period of time, 10-fold, sorry, from 4 to about 0.6. And now weight loss surgery is equivalent to hip or knee replacement when it comes to safety. And we showed that going to accredited hospitals makes a difference. This is a study I did a few years ago. And what you can see here is if you go to these accredited hospitals like Stanford, you have less money spent, you have less complications, less mortality. These are our results at Stanford compared to other academic institutions, and you can see that we do pretty well. Now, how does it work? If you look here long term, what are the long-term results? You can see this is taken out all the way to 10 years. And you can see here at the bottom, this is a gastric bypass, this is the sleeve, and here's the band. And you can see that at the end of 10 years, if you happen to weigh 300 pounds, you would have lost 100 pounds. And people do keep it off all the way out to 10 years. This is our results at Stanford. People start out roughly at a BMI of 50, and at the end of 1 year, they're down to a BMI of 30. Remember the diabetes, the high blood pressure, the sleep apnea, all that stuff I talked about at the beginning. Here are the results at the end of the year. Diabetes goes away 82% of the time, and that means no medications, no insulin. And that's a very good result for anybody. Now, in comparing the different procedures, you can see on the left here, this is the band, here's the bypass, here's the sleeve, Everybody loses weight. It looks like the bypass is a little bit better. All the high blood pressure rates go down at the end of a year. The diabetes, of course, has a tremendous effect. Cholesterol gets better, even acid reflux gets better. And as I can show you from this national study, you can see here that patients really improved when it came to mortality. And like I said before, the national mortality rate now is about 1 out of 1,000. So it's become extremely safe. One other study to show you here is the impact that weight loss surgery in this circumstance had on people's life expectancy. This is a study that looked at patients who had surgery versus those who didn't, and I'm sure the results will be the same no matter how you lost the weight. But you can see here that people who underwent surgery, their mortality rate decreased by 40% at the end of 5 years. Pretty tremendous results. And you can see that the deaths associated with those other diseases also went down. There was one spot where we did see mortality rates go up afterwards, and that was around accidents and suicides. And the one thing I want to emphasize there is that substance abuse is likely associated with that, okay? Suicide rates do go up if you are having substance abuse issues, if you're drinking, and certainly accidents are associated with alcohol. 50% of patients who come in for major traumas usually have alcohol on board. So that just points out one thing. As a result, we were curious to see what happens to patients after they have weight loss surgery and alcohol. This is an old study I did a long time ago because people didn't know the answer to this question. And what we did is recruited patients to have a single glass of red wine before surgery and then after surgery. We had no trouble recruiting patients for this study. We had a lot of folks who were interested in it. And these are the results that you can see here. And if you look, the blue line is before surgery and the yellow line is after surgery. And you can see that their breath alcohol level with that single glass of red wine was above legally intoxicated. So it's important to keep that in mind. Just like you don't drink and drive now, don't drink and drive in the future. Don't forget, alcohol has calories, something else to kind of keep in mind. I showed you 10-year data. There's also, as you can see, your 14 and 7-year data. I've been here at Stanford since 2003, and we've had 14-year data in place, so our results are durable. The other thing is we're committed to lifelong follow-up. We see our patients at least once a year for the rest of their lives. Obesity is a chronic disease. We want to be there to help when there are issues that may come up. Now, I wouldn't be a weight loss surgeon or specialist if I didn't have some show and tell pictures. You can see here one of our patients, and you can see there that she was able to get rid of her diabetes, her high blood pressure, sleep apnea. But you know the thing that she appreciated the most? Being able to get on a plane and not worry about being given a belt extender, you know? And for us, we don't often think about it, but you know, if you carry an extra weight, you think about those things. You think about, am I going to be seated in a booth at a restaurant? Am I going to be able to fit? And it may sound like a little thing, but life is a series of little things. And so if we're able to increase your quantity and quality of your life, we're happy to do that. We're not too far away from Lucille Packard, where we also do weight loss surgery for young adults. We don't do a lot of it. We're very careful about who we operate on. But as you can see in this one young lady's example, that she was able to lose weight and really improve her health. This is another one of our patients who was having a lot of issues with diabetes, was taking a lot of insulin, and one of her motivations to seek care was the fact that her grandmother passed away from complications associated with diabetes and Alzheimer's. You know, and one of the things that can happen as we get older and we carry extra weight is we actually increase our risk of dementia. And that's something we all have to think about because of all the things associated with it. We do have some evidence to show that your cognition, your ability to think and remember and process things, improves with a better diet, low carb, improves if you're able to control blood sugar. All those things make it better. So we did a study with our patients before and after surgery, and what we found were the following. This is one of the tests. This just sees how quickly you can connect numbers 1 through 25 without lifting your pencil from the paper, and you can see you're graded on speed and accuracy there. And at the end of 6 months, we looked at all those different tests that we did, and they all improved in as little as 6 months. And cognition refers to your ability to remember things, to process things, verbal fluency. So patients not only lost weight, maybe they got a little smarter in the process too. So something else that you can see. One thing that we're all worried about as we get older is the effects of aging, you know, how sharp we'll be. And one of the markers for aging, we have genetic markers for it, it shows how fast you're aging. And there are these things called telomeres, and they're at the ends of chromosomes. Our chromosomes constantly divide, and these are caps on the ends of those chromosomes to help protect the genes. It reminds me a little bit about these things at the end of shoelaces, so they don't unravel. So this is something that we also looked at, the genetic material, and what we found was that our patients with losing weight, their telomeres actually got longer, which indicates that the aging process had slowed down. So that's something that's super important for our patients. One thing I also want to emphasize is that this is a problem of all gender, whether you be male or female. And you can see here, this is one of our patients who sought our care because he's worried about diabetes, but the other thing he was worried about was his testosterone level was dropping. And you can see here that in the study we did, as male patients' weight went down, their testosterone doubled. You see all those ads for low T on the news and stuff like that. The best thing to increase your testosterone if you're a man who's carrying extra weight is to decrease your weight, and that'll make your testosterone go up. And the reason for that is fat around our tummy gets converted into estrogen, and that will drive down testosterone. And as I'll show you in the next slide, carrying extra weight is not good for a woman either. This is one of our other patients. You can see there that she had her baby, was very happy. She had tried many years to get pregnant and couldn't because of her weight, spent a lot of money on all those fertility drugs. And then about a year after surgery, and we don't recommend that people get pregnant in that first year because you're losing weight too quickly for either yourself or your baby. But a year later, she had her baby, and we also did a study to show that if people are able to lose weight, you can have a safer pregnancy. And you can also have the ability to become pregnant at a higher rate. I have one more patient to show you here. This is a former high school wrestling coach, and you can see him there. He was referred to me by his cardiologist because they were at wit's end. He had open heart surgery twice. He was on several different medications to help him with his heart, and they were still worried about him. And one thing that we still know is that heart disease is still the #1 killer in the United States. We've done a very good job, as you can see there, with smoking. But unfortunately, we've replaced that with carrying extra weight. And if I show you the maps for obesity and if I show you the maps for heart disease, they look virtually the same. So we did a study a while ago where we showed the improvement in cardiac risk factors. Things like total cholesterol. You can see here about a year after, people dropped their total cholesterol by 20 points. LDL, the bad cholesterol, went down almost by half. HDL, the good cholesterol, went up almost by 20 points, which is hard to do. Triglycerides went down almost by half. And you can see some of the newer ones also improved. Now this last one, if I had to pick one test to predict future heart risk, it's probably this one. It's called C-reactive protein. It's a measure of inflammation. And it ought to be less than 3, anytime you get it checked. And you can see here our patient started out at 8. And at the end of 1 year, they were back down to 1.4. Here's our coach. You can see him there. And here he is after surgery. So you can see what a dramatic improvement for him. And I started out this talk by talking about the impact that you can have for yourself if you're able to address those 4 competencies of weight loss: diet, exercise, sleep, and stress management. The lessons you learn around your diet and all those other things that I mentioned, pass them on to other people because it can have impact. And this is a good example of that. You can see husband and wife and their kids there, operated on husband and wife. You can see them there, and here they are about a year later. So you can see the kids didn't have surgery, but what they did have were good examples set for them by their parents, and they were also able to lose weight. We followed that up with doing a study that showed that patients who had surgery, their family members lost weight as well, and the kids did not increase their weight over time either. And this just shows what can happen when we work together. And I want to show this real short cartoon here about some of the things that are changing about obesity management. For the longest time, all we had was surgery. We're getting sharper and better about making lifestyle changes. We now have tons of medications that can make a difference. And of course, the endoscopic solutions that I talked about, like the intragastric balloon. Imagine if we got all that working together along with surgery. The end of this is to say that there is hope. There's something that you can do about your weight. Do not think that it's hopeless. There's a lot of options available to you, regardless of stage of disease. Stanford's a teaching institution, and we do learn from all of our patients. They can teach us lessons in many different ways, and we try to learn those lessons through the research, and you can see we're doing a lot of research over time. I want to show a really short video here that illustrates stories of 3 different patients.
Weight loss surgery is just a procedure to get you where you need to be. I meet people and they don't think of me as fat. I'm just another guy. That's amazing to me, but that's not the first thing people see anymore.
So I feel like surgery gave me back control of my life. It just gave me choices that I didn't have before. For that, I feel like it was a gift.
Start your weight loss journey today at itstartstoday.com.
So I just wanted to share those patient stories because I think they illustrate a couple of things. You know, one thing is that you can see the Navy veteran in that video. He certainly knows a lot about discipline. So it's not a discipline issue when it comes to weight. I think you saw the NFL player. It's not about physical activity. That guy certainly knows a lot about physical activity. And lastly, our nurse. It's certainly not a lack of medical knowledge. You know, so it shows that there's a lot that goes into it. But hopefully I've shown with the talk that we have a lot of options available. And my email's up there. Happy to answer any questions over email. Really appreciate everybody's attention. Thank you very much for the opportunity to talk to you guys tonight. Thank you.